Picture a standard medical consultation room. On the outside, a patient might look slightly tense, but beneath that calm surface, they are often navigating a terrifying internal world they are desperately trying to hide. This happens because psychotic delusions are what psychiatrists call ego-syntonic. To the patient, the voices they hear or the conspiracies they suspect aren't symptoms of an illness. They are absolute, objective facts of their reality. They also know exactly how those facts sound to everyone else. Acutely aware of the stigma and terrified of involuntary commitment, their most logical defense is absolute silence. This creates a massive invisible chasm in the room. On one side sits the doctor, anchored in objective reality. On the other sits a patient experiencing genuine terror. Without a way to cross that gap, the clinician is flying blind. If that doctor decides to just read down a clipboard and bluntly interrogate the patient about their mental state, they will destroy any chance of building trust before the evaluation even begins. A traditional medical approach relies on a straightforward hunt for facts. A doctor might naturally lean in and ask a direct question like, "Are you hearing voices right now?" When someone's delusion is their absolute truth, challenging the mechanics of that truth feels like a direct hit on their sanity. Instead of opening up, their psychological defenses harden instantly. To make progress, the clinician must undergo a counterintuitive shift. They must drop the instinct to correct the patient or disprove the delusion. The required tool here is profound, non-judgmental curiosity. The goal isn't to interrogate the facts, but to map the patient's lived experience. By temporarily setting aside objective reality, the interviewer can start to trace the emotional contours of the patient's internal world. This involves using indirect questioning. Instead of targeting the supposed conspiracy, you target the very real emotions and behaviors that the delusion triggers, like fear or isolation. Clinical guidelines for exploring psychotic symptoms state the evaluation must be conducted with curiosity and respect. A clinician might start gently. Do you feel uncomfortable in public? If engaged, they step closer to persecutory paranoia. Do you feel people notice you walking down the street? These questions are incredibly precise. They validate the patient's genuine feelings of vulnerability and lack of safety without ever confirming that a plot actually exists. By focusing purely on how the patient feels, these engineered questions serve as a structural bridge across that initial chasm, allowing the clinician safe passage into the patient's reality. You can often see the exact moment this dynamic shifts. The patient's shoulders might drop a fraction, or their defensive posture loosens, because they realize someone is finally acknowledging their fear without judging it. That small pocket of trust creates a safe harbor. It is from within this harbor that a patient will voluntarily start to test the waters, slowly revealing the actual details of their psychosis. Only after that bridge is sturdy can the formal clinical work begin. This text on sensory perception assessment shows how the doctor then explores complex alterations, like auditory hallucinations or disorganized thought processes. This rapport facilitates an accurate mental state examination. It turns a potentially hostile interrogation into a collaborative diagnostic effort, creating a treatment strategy that the patient can actually accept. In the high-stakes environment of psychiatric evaluation, empathy serves as the primary diagnostic instrument required to navigate the unseen.